Cholesterol and triglycerides are fats, and fats don't dissolve in blood plasma. So how does your body move them from the gut and liver to every tissue that needs them? It packages them into spherical transport particles, and the biochemistry of those particles is the entire HDL-LDL story. The answer is the lipoprotein, a spherical particle with a hydrophobic lipid core wrapped in an amphipathic shell, engineered specifically to shuttle water-insoluble lipids through an aqueous bloodstream. Every lipoprotein shares the same basic architecture: a hydrophobic core of triglycerides and cholesterol esters, surrounded by a single layer of phospholipids, free cholesterol, and Apolipoproteins, the amphipathic shell that keeps the whole particle soluble in plasma. Classification is based on density, determined by ultracentrifugation, and density is inversely related to lipid content. Chylomicrons are the lowest density, packed almost entirely with dietary triglyceride. HDL is the highest density, packed mostly with protein. That inverse relationship exists for a simple compositional reason. Triglyceride is lighter than protein. So a particle stuffed with triglyceride, like a chylomicron, floats at low density, while a particle built mostly of protein and cholesterol ester, like HDL, sinks at high density. Exam-relevant sizes worth memorizing. Chylomicrons are the largest particles, up to 1,000 nanometers. VLDL runs 30 to 80 nanometers. LDL is smaller still, around 18 to 25 nanometers, and HDL is the smallest of all, at just 8 to 12 nanometers. This is what they'll ask you on the exam. Remember, particle density and size move in opposite directions. Chylomicrons, biggest particle, lowest density. HDL, smallest particle, highest density. Get that inverse relationship locked in, and half the classification questions solve themselves. So before any function or pathway, get this structural foundation locked: a lipid core, an amphipathic shell, and a density classification that's really just a proxy for composition. Apolipoproteins do far more than hold the shell together. They're functional tags. They activate enzymes, they're recognized by specific receptors, and they determine exactly how a particle is metabolized and cleared. For apolipoproteins carry the overwhelming majority of exam weight. ApoB-100 is the structural backbone of VLDL, IDL, and LDL, and it's the ligand the LDL receptor actually binds. ApoA-I is HDL's main structural protein and activates LCAT. The other two high-yield apolipoproteins, ApoC-II, the obligatory cofactor that activates lipoprotein lipase to hydrolyze triglycerides, and ApoE, which mediates hepatic clearance of chylomicron and VLDL remnants via receptor recognition, line up which apolipoprotein sits on which particle, and the whole system becomes far more predictable. Chylomicrons carry ApoB-48, ApoC-II, and ApoE. VLDL and LDL carry ApoB-100, and HDL carries ApoA-I as its signature protein. A classic exam trap: ApoB-48 versus ApoB-100 are not the same protein, truncated differently for fun. They come from the same gene, but intestinal mRNA editing produces the shorter ApoB-48, while the liver produces the full-length ApoB-100 that the LDL receptor recognizes. Clinically, this matters directly. A deficiency of functional ApoC-II causes severe hypertriglyceridemia, since lipoprotein lipase can't be activated at all. Chylomicrons simply accumulate in plasma, undigested. Lock this down before moving on. B for binds the LDL receptor, ApoB-100. A for activates LCAT, ApoA-I. C for catalyzes lipolysis via LPL, ApoC-II. And E for excess clearance of remnants, ApoE. Apolipoproteins aren't decoration on the lipoprotein shell. They're the addressing system that tells enzymes and receptors exactly what to do with each particle. Now let's trace LDL's full life cycle, because LDL isn't secreted directly by the liver. It's the end product of a stepwise remodeling process that starts with VLDL. The liver secretes VLDL, rich in triglyceride. Lipoprotein lipase, activated by ApoC-II, strips out triglyceride at peripheral tissue capillaries, converting VLDL into IDL. Hepatic lipase then further strips IDL of remaining triglyceride, yielding cholesterol-rich LDL. LDL is then cleared by receptor-mediated endocytosis, ApoB-100 on the LDL particle binds the LDL receptor. The whole complex is internalized in a clathrin-coated pit, and lysosomal enzymes release free cholesterol inside the cell. This entire pathway was mapped by Michael Brown and Joseph Goldstein, who won the 1985 Nobel Prize in Physiology or Medicine for discovering the LDL receptor and defining receptor-mediated endocytosis as a general biological principle. Once inside the cell, free cholesterol does three things simultaneously. It suppresses HMG-CoA reductase, the rate-limiting enzyme of cholesterol synthesis. It downregulates further LDL receptor expression, and it activates ACAT to store excess cholesterol as cholesterol ester. One more high-yield regulator, PCSK9, a protein secreted by the liver that binds the LDL receptor and marks it for lysosomal degradation instead of recycling. Fewer receptors on the cell surface means less LDL cleared from plasma and higher circulating LDL-C. Common exam trap: PCSK9 doesn't degrade LDL particles themselves. It degrades the LDL receptor. That distinction is exactly why PCSK9 inhibitor drugs work by preserving receptor numbers, not by directly binding circulating LDL. Anchor the whole pathway with this. Liver makes VLDL, lipase strips it down to LDL, LDL receptor clears it, PCSK9 opposes that clearance. 4 steps, 1 clean line from synthesis to clearance. So LDL isn't a static particle. It's the output of a regulated remodeling and clearance system, and nearly every major lipid-lowering drug class works by manipulating one specific step in this exact pathway. If LDL's job is delivering cholesterol outward to tissues, HDL runs the opposite direction entirely, collecting excess cholesterol from peripheral cells and returning it to the liver, a pathway called reverse cholesterol transport. The pathway begins with nascent HDL, a small, disc-shaped, cholesterol-poor particle secreted by the liver and intestine, containing little more than ApoA-I and phospholipid, ready to start collecting cholesterol. 4 steps complete the cycle. ABCA1 transporters on peripheral cells effluxes free cholesterol onto nascent HDL. LCAT, activated by ApoA-I, esterifies that cholesterol, trapping it in the particle's core and maturing HDL into a sphere. CETP then exchanges some of that cholesterol ester for triglyceride from VLDL and LDL. Finally, SRB1 receptors on the liver selectively uptake HDL's cholesterol ester for excretion. Match each protein to its exact job and this becomes very memorable. ABCA1 exports cholesterol out of cells. ABCG1 continues that efflux onto maturing HDL. LCAT locks cholesterol in as an ester. CETP trades lipid classes between particles. And SRB1 is the liver's final cholesterol ester intake receptor. Contrast the two systems directly. LDL uses whole particle receptor-mediated endocytosis to deliver cholesterol to tissues. HDL uses selective lipid uptake via SRB1 to deliver cholesterol back to the liver. The particle itself isn't internalized and destroyed the same way. HDL's protective effect isn't limited to reverse cholesterol transport alone. It also carries antioxidant enzymes like peroxidase, one that inactivate oxidized lipids, and it has genuine anti-inflammatory effects on the vascular endothelium. Remember the sequence with this. Cholesterol goes out of the cell via ABCA1, gets trapped by LCAT, traded by CETP, and taken up by SRB1 at the liver. OTTT, 4 consecutive steps you can recite in order. So HDL isn't just the opposite of LDL. It's a distinct transport system with its own receptors, its own enzymes, and its own separate route back to the liver.
Quick pause. If this breakdown is helping you, take a second to hit like and subscribe. It genuinely takes a lot of effort to make videos like this, and your support keeps them coming.
Now connect both pathways to the actual disease process because LDL is bad, HDL is good is a useful shorthand, but the real exam-relevant question is, bad and good for exactly what mechanism? Here's what that plaque-building process actually looks like inside the artery wall: LDL infiltrating the intima, undergoing oxidation, and triggering the immune cascade that builds atherosclerotic plaque. LDL becomes atherogenic once it infiltrates the arterial intima and undergoes oxidation. Oxidized LDL is engulfed by macrophages through scavenger receptors, unregulated by normal feedback, turning macrophages into cholesterol-stuffed foam cells that form the core of atherosclerotic plaque. HDL counters this at multiple points. It physically removes cholesterol from the arterial wall via reverse cholesterol transport. Its peroxidase enzyme actually degrades oxidized lipids, and it suppresses endothelial adhesion molecule expression, reducing the very first step of plaque formation. Line the two mechanisms up directly for exam recall. LDL delivers and deposits cholesterol into the arterial wall, promoting plaque. HDL extracts and removes cholesterol from the same location, actively opposing plaque. An important, genuinely high-yield exam nuance. Raising HDL-C pharmacologically with niacin or CETP inhibitors has repeatedly failed to reduce cardiovascular events in large trials, meaning HDL's protective biology doesn't automatically translate into more HDL number equals less risk with every drug. So the real takeaway isn't LDL bad, HDL good, as a slogan. It's that each particle's specific biochemistry determines its specific effect on the artery wall, and treatment strategies live or die by that distinction. All this biochemistry eventually has to become a number on a lab report, and how that number is actually calculated is exactly the kind of detail that separates a good exam score from a great one. Most labs don't measure LDL-C directly, they calculate it using the Friedewald equation, derived from the fact that VLDL cholesterol can be estimated as triglyceride divided by 5, since VLDL particles carry a roughly fixed cholesterol to triglyceride ratio. Critical limitation, guaranteed to appear on an exam. The Friedewald equation becomes unreliable once triglycerides exceed 400 mg or DL, because the fixed TG to cholesterol ratio assumption breaks down. Direct LDL measurement is required instead in that setting. Three related values often get confused. Calculated LDL-C uses the Friedewald formula. Direct LDL-C is measured by immunoseparation or homogeneous assay, bypassing the triglyceride assumption entirely, and non-HDL-C is simply total cholesterol minus HDL-C, capturing all atherogenic particles at once. Current ACC or AHA guideline thresholds worth memorizing. For secondary prevention in patients with established cardiovascular disease, the LDL-C target is under 70 mg or DL. For primary prevention in high-risk patients, the target is under 100 mg or DL. One practical lab point worth knowing. Current guidelines increasingly accept non-fasting lipid panels for routine screening. Since triglycerides shift only modestly after a meal, fasting is really only essential when triglycerides themselves are the primary concern. Work through it as a decision path. Is the sample's triglyceride level under 400? If yes, calculated LDL-C via Friedewald is valid. If no, order direct LDL-C measurement instead, or default to reporting non-HDL-C. So the lipid panel isn't a black box, it's biochemistry you already understand, wrapped in a formula with one very specific, very testable limitation. This biochemistry shows up constantly in clinical medicine, both as genetic disorders that break specific steps in these pathways, and as the exact drugs used to treat dyslipidemia. Familial hypercholesterolemia is caused by mutations in the LDL receptor itself in ApoB100, or less commonly, gain-of-function mutations in PCSK9, all converging on the same result: severely impaired LDL clearance and markedly elevated LDL-C from birth. A classic cutaneous sign worth recognizing on sight: xanthelasma, yellowish cholesterol deposits around the eyelids, and tendon xanthomas, particularly over the Achilles tendon. Both point strongly toward an underlying lipid disorder. Statins are the cornerstone treatment. They competitively inhibit HMG-CoA reductase, lowering intracellular cholesterol synthesis, which upregulates LDL receptor expression as a compensatory response. High-intensity statins lower LDL-C by more than 50%. The two other major exam-relevant genetic disorders live at opposite extremes. Tangier disease, from ABCA1 mutations, causes near-absent HDL and orange-colored tonsils. PCSK9 loss-of-function mutations produce the opposite pattern, unusually low LDL-C and protection from heart disease. PCSK9 inhibitors, like evolocumab and alirocumab, work by the exact opposite logic of the natural protein. They're monoclonal antibodies that bind and neutralize PCSK9 itself, preserving LDL receptors on the cell surface and dramatically lowering LDL-C, often by 50 to 60% on top of statin therapy. Tie the whole chapter together with this Statins suppress synthesis, PCSK9 inhibitors protect the receptor, and the underlying genetic disorders FH and Tangier sit at the two extremes this entire pathway can produce. Every drug and every genetic disorder in this chapter traces back to one specific step in the pathways you already know cold. That's exactly what makes lipid pharmacology so learnable once the biochemistry is solid. Let's close by putting all of it to work on one integrated case. A 19-year-old male presents for a routine checkup. His father died of a myocardial infarction at age 42. Exam reveals bilateral xanthelasma and Achilles tendon thickening. Work through the reasoning the way an exam wants you to. Young age plus family history plus physical signs points to a genetic cause, not lifestyle. Elevated ApoB 100 containing particles from birth explains both the xanthelasma and the LDL number, and statin plus ezetimibe targets two separate points in the same pathway. Quick check before we close. A patient's LDL receptor is functioning normally, but PCSK9 has a gain of function mutation. What's the most likely effect on plasma LDL-C? Carry these numbers back to your revision notes. Friedewald validity cutoff at triglycerides under 400, secondary prevention LDL target under 70, high-intensity statins cutting LDL by over 50%, and PCSK9 inhibitors adding another 50 to 60% on top. If you remember nothing else from this entire video, remember this one line. LDL delivers cholesterol out to tissues, HDL brings it back to the liver, and nearly every clinically relevant lipid disorder is just one broken step in that two-way system. Before we recap, weigh the two major treatment strategies against each other honestly. Statins are cheap, oral, and first line for nearly everyone, while PCSK9 inhibitors are injectable, expensive, but deliver dramatically larger reductions for patients who need more. Grading the evidence honestly one more time. Statin therapy for both primary and secondary prevention has some of the strongest, most consistent outcome trial evidence in all of clinical medicine. This isn't a marginal recommendation, it's one of pharmacology's clearest wins. Structure, Apolipoproteins, the LDL pathway, reverse cholesterol transport, atherogenesis, lab measurement, clinical correlations, that's the complete lipoprotein story, and every piece of it is now testable knowledge you actually understand mechanistically.
Here are the key references and sources for this video. Thanks so much for watching. If this helped, like the video and subscribe for more clear, simple explainers, and I'll see you in the next one.